meeting leads was okay. So today we'll have a seminar. We already have seminar on benign breast diseases. Today we'll have seminar on management of carcinoma breast. We'll start with management of metastatic breast carcinoma because Malvika is taking time to join. So Dr. Snehasis Nath, the third year DND PGT at RKM Shivapadistan BIMS will present, and Professor Deependra Kumar Sarkar, who is Professor of Surgery at IPGMR and in charge of breast clinic, will moderate the session. Snehasis, you can share your screen and start. We'll take your session first. Okay. Snehasis.
Yes, sir. Am I audible, sir?
Yes, you are audible. Share your screen.
Thank you, sir. Good morning, everybody. So today my topic is management of metastatic breast carcinoma. So about 7% of newly diagnosed breast cancer patients have distant metastasis at the time of initial diagnosis, and about 24 to 30% of patients with node negative disease and 50 to 60% of patients with node positive disease will develop distant metastasis at follow-up if they do not die of their disease. The aim of treatment for the metastatic breast carcinoma patient are to provide palliation, to provide symptomatic relief, and symptomatic relief of symptoms due to growth in the breast which may be fungated. The modes of treatment are hormone therapy, chemotherapy, radiation therapy, and limited surgery. And the hormone therapy, it is effective in patients with ER positive, PR positive, ER positive, PR negative, ER negative, and PR positive cases. In 10% cases with ER negative, PR negative tumors may show objective response with hormone therapy. Hormone therapy agents are: first is tamoxifen. It is selective estrogen receptor modulator that has antagonistic and weak agonistic effect. It reduces the risk of recurrence in ER positive, PR positive patients. Beneficial effect in reducing the risk of development of contralateral breast cancer. It is given both in pre and post-menopausal patients, both in node positive, node negative patients, at the dose of 20 mg per day for 5 years. It blocks the uptake of estrogen by the target tissue after cortisol binding to the estrogen receptor. The side effects of tamoxifen include nausea, vomiting, transient hyperglycemia, fluid and electrolyte retention, increased incidence of endometrial carcinoma, and slight increase in thrombotic events. EBC TCG 2005 meta-analysis or study reported data from 80,000 patients administered for 5 years was found to have reduced the risk of recurrence of breast carcinoma with hormone receptor positive disease by 41%. The American Society of Clinical Oncology recommends 5 years tamoxifen therapy for both pre and postmenopausal women. After 5 years, if the patient is still premenopausal, she should be offered an additional 5 years of tamoxifen therapy. In the hormone therapy, there is another agent broadly known as aromatase inhibitors. Two types of aromatase inhibitors are there. First is non-specific, it is aminoglutamide, and specific, those are anastrozole, exemestane, letrozole. They are unable to suppress ovarian function completely, therefore reserved for the postmenopausal woman. Among the side effects are the hot flushes, vasomotor symptoms, joint symptoms, myalgia, bone loss, and vaginal dryness. Alone or in combination, ATAC trial demonstrated that 5 years of anastrozole significantly increases the disease-free survival by 17% as compared to tamoxifen alone. American Society of Clinical Oncology recommends if pre or postmenopausal woman has received 5 years of tamoxifen, then we should offer total 10 years of tamoxifen therapy. If women are postmenopausal, then they should be offered either to continue the tamoxifen or to switch over the aromatase inhibitors for another 5 years. So, in case of premenopausal women, the first line therapy is tamoxifen. Second line, if there is response to tamoxifen, ovarian ablation with surgery or radiation may be considered. Luteinizing hormone-releasing hormone analogs like goserelin brings about reversible chemical castration by suppressing gonadotropin release. And third line, progestin, magistral. Sorry, sir, here is a typing mistake. Luteinizing F should be G. Sorry, sir. And third line, progestin, magistral acid. And in case of postmenopausal women, the first line therapy is the anti-estrogen like tamoxifen. Second, like aromatase inhibitors, anastrozole or letrozole. And third line is progestin. Now, chemotherapy. The agents being anthracycline act as topoisomerase 2 inhibitors like the doxorubicin, epirubicin. This group of drugs have the side effects like cardiomyopathy, which may lead to congestive cardiac failure, the incidence being reported from 1.5 to 3%, and leukemia, the occurrence being less than 1%. Other agents are taxanes, those are microtubule inhibitors. Side effects include peripheral neuropathy. HER2-based targeted therapy. HER2 gene amplification or protein overexpression occurs in approximately 20 to 25% of breast carcinoma patients. Trastuzumab is a humanized monoclonal antibody developed to target the extracellular domain of HER2 receptor. The HERA Herceptin adjuvant trial, trastuzumab reduced the risk of a cancer-related event by 46%. Also concludes 1 year of treatment as standard of care. Use of trastuzumab plus pertuzumab is approved in all disease settings. Trastuzumab or neratinib is approved in adjuvant settings. Trastuzumab lapatinib in metastatic disease. Trials are ongoing with further combinations with PI3-AKT, mTOR inhibitors, anti-PD-L1 antibodies, endocrine therapy, and new anti-HER2 agents. The chemotherapy agents are the following: CMF regime comprising of cyclophosphamide 500 mg per meter square, methotrexate 10 mg per meter square, and 5-fluorouracil 500 mg per meter square. CAF cyclophosphamide adriamycin 5-fluorouracil, FC cyclophosphamide 5-fluorouracil, AC cyclophosphamide, here the dose will be 600 mg per meter square, and adriamycin 60 mg per meter square. TAC docetaxel doxorubicin cyclophosphamide, TC docetaxel and cyclophosphamide, AC that is cyclophosphamide and adriamycin, followed by paclitaxel and trastuzumab, TCH docetaxel, carboplatin, and trastuzumab. Those are continued for 6 to 12 cycles, usually 21 days apart. Role of high-dose chemotherapy. There are trials with high-dose chemotherapy with cyclophosphamide, cisplatin, and carmostin, and melphalan along with bone marrow support, like the granulocyte CSF. Now, radiotherapy. Radiotherapy to the breast and lymph node field in selected cases. In case of bone metastasis, radiotherapy provides dramatic pain relief due to tumor shrinkage that relieves periosteal tension and also direct inhibition of humoral factors such as prostaglandin. Pathological fracture of bones need surgical stabilization. In case of brain metastasis, whole brain irradiation and solitary brain metastatic by stereotactic radiotherapy or surgical excision. Spinal cord compression, early radiotherapy is very effective. Internal fixation may be required for vertebral stability. In case of liver mets, radiotherapy may provide effective palliation in symptoms. Breast is irradiated to a dose of 4,500 to 5,000 centigrade divided in 200 fractions per day for 5 days in a week. Local boost radiotherapy at a dose of 1,000 centigrade delivering high dose to the breast tissue. The role of surgery for the primary lesion, simple or toilet mastectomy. For the lung mets, resectable disease confined to one lobe, one lung resection. For brain mets, solitary metastasis may have some role undergoing surgery. For hepatic mets indicated in those whose disease at other sites is controlled with systemic chemotherapy. Ovarian ablation, second line of hormone therapy in premenopausal women. LHRH analog may bring about reversible chemical castration. Supportive therapy for bone mets, treatment targeting osteoclast activity to prevent bone fracture, bone pain, hypercalcemia, spinal cord compression, and skeletal related events. Agents are bisphosphonates, gelotonic acid, and palmitronate in combination of oral calcium and vitamin D3 may be used up to 2 years. Denosumab, monoclonal antibody against receptor activator of nuclear factor kappa B ligand, which is mediator of osteoclast function. Thank you, sir.
Thank you, Snehasis. Now, may we start with some basic questions, okay? You have rightly, underlined the whole program. You can share yourself now. You can come out of the slides and we can discuss things directly.
Yes,
okay.
Yes.
Now, point number 1, Snehasis. The question that I'm going to ask you is, if a lady presents to you with a metastatic disease, there are two different forms by which a lady can present. Number 1, a patient can present to you with metastatic disease to begin with. The other group of patient is a patient who had undergone a surgery previously and now have developed metastasis. So these are the two subset of patients. Now,
Yes, sir.
If a patient presents to you with as such a metastatic disease to begin with, how will you approach?
Sir, approach to the metastatic breast carcinoma patient begins with clinical examination and detailed investigation also to be done, like as core needle biopsy from the breast lump.
Breast lump.
Yes, sir, and axillary lymph node status, ear, PR, heart new status of the tumor can also be done with the core needle biopsy samples. And for the other investigations, I would also like to perform the chest X-ray, routine liver function test, USG and CT scan of the abdomen, whole body scanning if possible, and other like if affordable to the patient, then CT scan brain, skeletal survey, CT scan of the chest, depending on the site of the distant metastasis, and all routine visual investigations, sir.
Okay, Snehasis. So Snehasis, basically the metastatic workup comprises of routinely, if the patient is asymptomatic for a locally advanced breast cancer, the metastatic workup comprises of CT thorax, CT abdomen and pelvis and bone scan. There is another group who feels instead of these three, you can go for a PET CT scan directly, which is also
yes, sir, the whole body. Yes, sir.
Okay. Now you have picked up a metastasis, say in the bone. How will you plan to deliver treatment? And now let the patient be how will you approach to the patient with a primary in the tumor and multiple bone mets?
Sir, primary tumor, if it is resectable, then it should be resected by simple mastectomy or toilet mastectomy. Then for the bone mets, the radiotherapy is very much effective.
Now let us take one by one.
Yeah.
You tell us what is the indication of surgery of the primary in case of metastatic breast cancer?
Sir,
In
role of
metastatic
surgery.
disease, we will do upfront primary surgery. Is it the recommendation? If you already said that treatment is palliative.
Yes, sir.
So if you are having a diagnosis of bone mets with the primary in the breast and their primary is not fungating, so would be the upfront surgery of the breast is a recommended step.
No, removal of primary lesion of the breast is not compulsory, but sir, if the lesion is, fungating lesion or something like that, then toilet mastectomy or simple mastectomy can be done, sir, for the primary lesions.
Okay, Snehasis. So no longer we use the term toilet mastectomy. We call it a palliative mastectomy or a salvage mastectomy. Okay.
Yes, sir.
So
Yes, sir.
now we were, as sir is rightly pointing out, that if a patient presents to you with a non-fungating mass, with
Yes,
a lesion in the breast, with metastasis in the bone, how will you approach to manage this patient? Surgery
Sir,
first or
yes, sir. The aim
systemic
of the
therapy
yes,
first?
sir, yes. Sir, aim of the treatment is to provide the palliation and symptomatic relief. So if the tumor in the primary lesion of the tumor in the breast is not causing any apparent symptoms like compression effects or something like that, and then palliation can be done with the hormone therapy, chemotherapy, radiation therapy, and surgery is limited only for the surgery is reserved for the while when it is required for symptomatic relief only, and
But
for the hormone therapy, sir,
okay.
if the woman is premenopause, has sir.
Now, what would be the role of surgery in which subset of patients without fungation surgery has a role?
Yes, sir.
It is called, I suppose you probably do not know it, so you need to understand that there are two types of disease. One is called an oligometastatic disease, the other is called a polymetastatic disease. Oligometastatic disease is one in which there is metastasis in less than 4 sites, okay, in possibly in bone. So in case of oligometastatic disease, primary surgery, that means 3 or less. So in
Yes,
case
sir.
of 3 or less metastatic spots, you can offer the patient surgery, because in this subset of patients, there is improvement in survival by doing a surgery. But if it's a polymetastatic disease, you should not be offering surgery to the patient unless there is fungation, bleeding, or such complications which is endangering the quality of life of the patient. So is it clear, Snehasis?
Yes, sir. Yes, sir.
So keep in your mind that polymetastatic disease and oligometastatic disease. So polymetastatic disease, the only indication of surgery is palliation. In
Yes,
oligometastatic disease, yes, you can offer surgery provided the number of metastases is less than 3. Yeah.
okay, sir.
The next question is, while you are planning to offer treatment, what are the important factors to be taken into consideration? Okay,
So
I
the
understand.
number of factors include, sir, the patient own factors, the tumor biology, ERTR, the hormone status of the tumor, disease-free interval from the initial treatment, where the metastasis took place, the site of the distant metastasis, and I think
Okay.
these are the
Now
factors.
Yeah, you are appropriate. You are almost correct. Now, of course, the patient status, whether the patient will be able to sustain, and what is the performance status of the patient, what is the ECOG status and the Karnofsky score of the patient. If the patient is able to accept systemic therapy, then you will offer systemic therapy. If the patient is unable, then you have to think in terms of non-systemic therapy palliations. Point number one. Point number two is what is the rightly you told that molecular biology status. Now, suppose this is a luminal malignancy, what would be luminal means luminal A or B, that is ER positive, PR positive, HER2 negative cancers. So what will be your policy at this level?
So if the patient is premenopausal, then first line therapy should be starting tamoxifen 20 milligram per day, and then yes sir.
No, starting blindly tamoxifen is not going to help in such patients, okay? Because you can divide it again as I said, it's a bone only disease or it's a visceral metastasis. Do you get my point?
Yes,
so point
yes,
number one is the treatment. What is the presentation of the patient? Point number two is the type of molecular biology the patient is facing, and number three is
yes,
where is the metastasis located. Clear?
Yes, sir.
Now,
Yes.
if it is a bone only metastasis and molecular biology wise it comes out to be ER positive cancer, then it's a bone only metastasis, then you can begin with hormone therapy. Clear?
Yes, sir.
If
Yes, sir.
it is a visceral metastasis, then you cannot rely only on hormone therapies. You have to start with upfront neoadjuvant systemic therapy, chemotherapy, so that because the action of chemotherapy is faster compared to hormone therapy. Not that hormone therapy is inferior, but chemotherapy is superior in terms of faster action. So you give chemotherapy fast so as to control the disease, and then when there is some amount of remission, you can think of shifting to hormones. Clear? So the molecular biology and where the metastases have taken place, and how many number of metastases and what is the performance status. These are the four factors based on which you plan a treatment. Now, one, of course, you told about tamoxifen, you told about aromatase inhibitors. Can you tell us about some newer hormonal agents which you can use? Okay, if you do not know, Lepatinib is not a endocrine manipulation.
Newer hormonal agents, I don't recall, sir.
Okay, let me tell you, the basic one, as you rightly said, is tamoxifen. In a premenopausal lady with or without goserelin, if you want to convert the patient into a postmenopausal status, you can also choose to have an ovarian ablation or a surgical oophorectomy done. And then why you offer that? Because as the patient becomes postmenopausal, you have a large array of treatment options. The simplest one, as you rightly said, is aromatase inhibitors, which comprises of reversible and irreversible. The reversible one is the letrozole or
anastrozole, letrozole, exemestane.
Exemestane is usually irreversible blocker. Okay. Now there are certain second lines which you did not tell us. Number one is called fulvestrant. Okay.
Yes, sir. Yes.
Number two is very important is CD4 blockers, which are called the ciclips, which starts with palbociclib or ribociclib. What are the names did I tell? Palbociclib and ribociclib.
Yes, sir.
Okay, so you can put in a combination of, say, anastrozole with or a letrozole with palbociclib, letrozole with fulvestrant. Clear?
Okay, sir.
So Number one is you can flatly start with aromatase inhibitors and then shift on to the combinations of aromatase inhibitors in the form of AI with fulvestrant, AI with palbociclib. Okay. Now what happens is that if you are using this medicine for some time, the hormone receptors, there is mutation in the cell line, and you have written certain things there which are called mTOR pathways. Haven't you written that
Yes,
there?
sir. Yes. Yes,
So
sir.
what are these pathways? They are around. Now, if the ER receptor is situated on the membrane and its action goes inside the cytoplasm and then into nucleus, down the line, there are certain modifiers which are called mTOR or AKT3 pathways. Now, if there is a mutation in them, even if the patient is still expressing ERPR, after some time the action does not happen. Okay, and that is because of mTOR pathway mutation. For them, you can offer another medicine. Okay, the name of the medicine is everolimus. What did I call?
Everolimus.
Everolimus. The purpose of using everolimus is once again that pathway starts functioning. Now, if you give a combination of hexamarsen with everolimus, then what happens is that the hexamarsen works as the aromatase inhibitors and the pathway blockade is being taken care of by everolimus. Clear? So, as just to sum up on bone, we have or say ER receptors. You can start anastrozole or tamoxifen with its combinations. The combinations can be fulvestrant. The combinations can be everolimus. The combinations can be with ribociclib or palbociclib. Clear? Now we come to the next set of patients. So number one set of patients that we discussed is patients who are luminal cancers or ER positive cancers. Now we go to the second subset of patients who are HER2 enriched cancer. Clear? So basically they are HER2 3+ cancers with ERPR being negative. Clear? Now you rightly told what are the options for them. Basic option is trastuzumab, isn't it?
Yes, sir.
Or you told about combinations of trastuzumab with pertuzumab, trastuzumab with nair, and not lapatinib is not used in combination, but basically the commonest use is trastuzumab with pertuzumab. Clear?
Yes, sir.
Now remember that trastuzumab is a HER2 blocker. How does this pertuzumab works? It's a HER1 blocker. So if you give a dual blockade, it takes care of the HER2 pathway. Clear?
Yes, sir.
Now you initially start either with trastuzumab only or a combination of trastuzumab and pertuzumab. After some time, you might find that once again the drug or the medicine is not working again, and that is because of the resistance. Now in this case, you have the option of converting to a medicine called PDM1. What did I tell? PDM1. Now PDM1 is a combination of chemotherapy and HER2. Now what happens is that it goes into the focused area and combines the actions of chemotherapy and trastuzumab therapy in a localized, focused, bone-guided therapy. Clear?
Okay.
The next line of treatment is lapatinib with capecitabine. That is also a form of treatment that is being used. So what are the forms I told you? Herceptin, I mean trastuzumab with pertuzumab or trastuzumab alone. Then if it fails, you can move on to TDM1. If it fails, you can move on to lapatinib with capecitabine combination. Clear?
Okay, sir.
So As I said, molecular biology wise, A is luminal cancers, and we discussed about the types of hormone therapies. Number 2 is HER2 enriched cancer. We discussed about the different forms of therapy. Number 3 is triple negative breast cancer, or TNBC. So naturally, if it is a triple negative breast cancer, it will not work against either the endocrines or against the HER2 blockers. So in them, you are left with only one option, that is chemotherapy. Clear?
Yes.
Now, if you use chemotherapy, the common chemotherapy that is used is a taxane-based chemotherapy with a combination of platins.
Yes.
Now, recently we have a new form of treatment which has been tried in these patients, and it has given wonderful results. What is this? This is called immunotherapy. Okay, Snehasis, what did I tell? Immunotherapy. Now, immunotherapy acts against a particular receptor combination which is called PD-PDL1. Clear?
PDL1.
Now, PDL1. Someday I will explain you how exactly it works. But if you want to target these receptors, so this is a wonderful method also. Now, just to briefly make you understand what happens if you have a metastatic breast cancer and it's a triple negative breast cancer, and how immunotherapy works. Now, try to understand. I give you an example, then you will understand how it happens. Now, look at, say, COVID-19 virus. Any area where you are unable to understand, let me know. Now, it's a virus which enters into our body, and there is a cytokine storm. Why? Because the body recognizes it as foreign and tries to destroy it, and at times it over destroys and kills the host itself. So that is COVID-19. It's quite simple, isn't it? You understood? The second is, there are certain group of diseases like, say, autoimmune diseases, where a part of our gene sequence is changed, and the part of the body sequence is changed, and the body suddenly recognizes these as foreign, and so they start reacting to this. So what do you require in them? You require steroids in them, because steroids are going to suppress the hyperimmune function that occurs because of the autoimmune phenomenon. Clear, Snehasis? That also you understood?
Yes, sir.
Now we have the third form of disease, that is cancer. Now in cancer, what happens is that we similarly have changes in our genetic sequence. But unfortunately, there is no cytokine storm, which we expect, which we find in viral diseases, which we find in autoimmune diseases. Why? Because our body does not recognize the change that have happened within us. They still feel it's not foreign. But if there is a method by which we can make it look foreign, then we would be able to destroy these cells. And immunotherapy is a mechanism by which these checkpoints are activated. So now the body recognizes them as foreign, as a result of which what happens is that the T regulatory cells, the cytotoxic cells, they are activated, which destroys the cancer cells. So immunotherapy is a mechanism by which you activate cell death, because the body were unable to recognize them as foreign within our system. And these newer forms of immunotherapies have revolutionized the treatment. They are toxic, they are expensive, but we have a big hope in triple negative breast cancer. The other important thing in triple negative breast cancer is, if the lady is less than 50 years of age, there is high possibility that they are BRCA positive. Now, if they are BRCA positive, then we have a new medicine which is called olaparib. And this olaparib is able to actually halt the disease for a prolonged time. Clear? So once again, before we end, we summarize, because we can go on discussing on metastatic breast cancer for long.
Yes.
But basically the points you must remember that surgery has role if the patient requires palliation. Surgery has role if it's an oligometastatic disease. Number two, if it's a luminal cancer, then aromatase inhibitors and its combination cell. If it is a HER2 enriched cancer, then you go phase wise. You start with trastuzumab with a combination of trastuzumab and pertuzumab. Then we go into a combination of TDM1. Then you go in, as I said, the last one, lapatinib with capecitabine. If it is a triple negative breast cancer, then you have chemotherapies, or if the patient can afford, and if it's the PDL1 expressing cancer, in that case, we give immunotherapies. And it's called pembrolizumab. Then you have atezolizumab. And finally, if it's a BRCA1 or 2 expressing cancer, in that case, we can use a medicine, as I said, olaparib. Clear?
Okay. Yes, yes. Dr. Sarkar, we have another topic for discussion.
Yes, sir.
Dr. Malavika Rao is a third-year resident at Apollo Clinical Hospital. Will present on locally advanced breast cancer management. Malavika, you share screen.
Hello?
I'm just sharing this. Yes, Malavika, you can start.
Yes, sir. This is management of locally advanced breast cancer. Next slide, please. Locally advanced breast cancer is basically defined as stage 3 disease. So the tumor can be more than equal to 5 centimeters. This is not an either or scenario. Tumor more than equal to 5 centimeters, extensive nodal disease, invasion of skin or chest wall, and inflammatory breast carcinoma also comes under LABC. Inflammatory breast carcinoma is it's a very rare type of carcinoma, less than 3% incidence. It's characterized by skin changes, basically, which may or may not have a breast lump associated with it. So the skin changes, as we usually have, is brawny induration, erythema, satellite nodules, and pod orange. And since it's classified as stage 3B disease. Now, and this is a mammography of the inflammatory breast carcinoma. How do you diagnose and work up the patient? First is history and physical examination, bilateral mammography, image-guided core biopsy of the primary tumor, and if there are any suspicious axillary lymph nodes on clinical examination, then it is good to take the biopsy from there as well. We give a hormone receptor, and there is estrogen and progesterone receptor and HER2 receptor status. Bloods, especially, we will have to do liver function tests. And even though we do a routine bone scan and all of them, we will look for elevated ALP levels and elevated bilirubin levels to check for any liver metastasis. We have to do a complete metastatic workup, which includes HRCT, chest, abdomen, and pelvis, ideally with contrast. Bone scan and PET CT scan. That is, you can do a whole body PET CT scan instead of doing the CT scan separately. Next, the principles of management of the flow chart for management is once the carcinoma is stage, you do metastatic workup, and after excluding metastasis, start neoadjuvant systemic therapy. We assess the clinical response, and then based on the response to neoadjuvant therapy, if there's a complete or partial response, you go ahead for surgery and follow-up, adjuvant therapy after that and follow-up. And if there is no clinical response or progression, then we either we have to change the regimen used for neoadjuvant systemic therapy, and then you have to individualize the local regional therapy based on the response. Next slide. Yes. That we control the local regional disease and control the systemic disease. In controlling the local regional disease, we have surgery, neoadjuvant, that is neoadjuvant chemotherapy and radiotherapy. The alignment is completely gone. But for local regional disease, it's surgery, radiotherapy, and neoadjuvant chemotherapy. And for control of systemic disease, it is adjuvant chemotherapy. Next slide. So for neoadjuvant chemotherapy, which is what we give pre-operatively, the principles is that it provides an in vivo sensitivity chemotherapy. It downstages the tumor and permits an arterial resection, and it provides additional time to plan for breast reconstruction and adjuvant therapy. As the last one is relative. After the neoadjuvant chemotherapy we have to monitor the response to the therapy, and which is monitored by the RECIST criteria, that is response evaluation criteria in solid tumors. So it is classified based on the response. If it's classified as a complete response, a partial response, stable disease or moderate response, and progressive disease, which means the disease is progressing onwards. If it is a partial response, is less than 30%, less than 30% of the tumor has shrunk. Complete response is complete. The neoadjuvant chemotherapy regimens, which is are similar to the adjuvant chemotherapy regimens. Basically, what we use is anthracycline-based regimens along with taxanes. In hormone-positive tumors, for ER-positive tumors, chemotherapy is a very poor mode to shrink the tumors. So it is now found that we can give endocrine therapy as well, especially in postmenopausal strongly ER-positive tumors. We can give endocrine therapy, which is tamoxifen and aromatase inhibitors. We can give that as neoadjuvant chemotherapy for strongly positive strongly ER positive tumors in postmenopausal patients, which has a better outcome than chemotherapy. And for HER2 positive tumors, similarly, we can with usual anthracycline-based therapy with taxanes, and addition of trastuzumab to this combination has increased the pathological complete response rates. Next slide, please. Following neoadjuvant chemotherapy, we monitor the response. Now we monitor the response based on imaging modalities. There will be a clinical as well as a pathological response, which is measured, which is with imaging modalities and physical examination. Following which you do surgery. Now, surgery, there are multiple options that can be given for surgery. The usual modality we go for is modified radical mastectomy. There's certain other options. If the tumor has downstage, then we can also offer breast conservation surgery along with axillary lymph node dissection and radiotherapy following that. Or we can also go for total mastectomy or extended mastectomy, which is mastectomy plus level 1 lymph node dissection, or skin sparing mastectomy, which is becoming very common for cosmetic reasons. We also have Halsted radical mastectomy, which is done for progressive disease purposes, not responding to neoadjuvant chemotherapy. Patty's modified radical mastectomy is the standard, which involves excision of the entire breast tissue, nipple areolar complex, pectoral fascia, axillary tail of Spence, and level 1 to 3 axillary lymph nodes. And what we preserve is the pectoralis minor muscle, which can either be divided or you can also retract it. Then axillary vessels, thoracodorsal pedicle and nerve, long thoracic nerve, medial and lateral pectoral nerves. Complications of surgery, as we know, are seroma. Lymphedema is very debilitating and should be identified early, and the treatment should be started. We can either have is physiotherapy or compression bandages, and in extremely advanced cases, there is surgery for lymphedema. Then can it have injury to any to the nerves that are we are supposed to preserve? So long thoracic nerve injury will cause bleeding of scapula. Injury to thoracodorsal nerve will cause weakness while abduction and internal rotation of the shoulder. And medial or lateral pectoral nerves will cause atrophy of the pectoral muscles. We have vascular injury, which is injury to the thoracodorsal pedicle or the axillary nerves, which needs to be repaired intraoperatively. Next slide. Next slide, please. Then we come to the adjuvant systemic therapy, which is chemotherapy, radiotherapy, and hormonal therapy. So the principles is to prevent local recurrence, be eliminating distinct micrometastasis and distinct metastasis. So indications for systemic therapy, it's given in all patients, but in indications which we calculate is if there are positive lymph nodes, especially 4 or more positive lymph nodes, or 2 new positive disease, grade 3 disease that is poorly differentiated, if there is any lymphovascular invasion, and in triple negative tumors, we have to give chemotherapy. Next slide, please. Next slide, please. Next slide. As my colleague has already said, these are all the different regimens that are available. This is taken from the NCCN guidelines, which she has already enumerated, so I won't go through it again. Next. Then we go for the hormonal therapy. We have anti-estrogen therapy. It can be a selective estrogen uptake receptors, aromatase inhibitors. Aromatase inhibitors are there, and we have ovarian ablative techniques. So SCRM is tamoxifen or chloromethine, and this blocks the uptake of estrogen by the breast tissue, must be taken for a minimum of 5 years, and for premenopausal patients can be continued up to 10 years. Only for hormone positive tumors. It should not be given concurrently with chemotherapy because it acts on different cell cycles. Chemotherapy acts on actively dividing cells, and tamoxifen acts on the G1 phase of the cell cycle. So if when adjuvant chemotherapy is given, first we give chemotherapy followed by tamoxifen therapy after the completion of chemotherapy. The side effects are endometrial hyperplasia, increased incidence of endometrial cancer, and thromboembolic events. We also have ER down regulators, which Sir has mentioned, fulvestrant, which is still in trial. Then aromatase inhibitors, we have non-steroidal and steroidal. Non-steroidal is anastrozole and letrozole. Steroidal is exemestane. It inhibits aromatase enzyme and prevents peripheral conversion of the estrogen. It is the first-line treatment for postmenopausal patients. And if menopause was achieved due to chemotherapy or ovarian ablation, we have to first check the FSH, LH, and estrogen levels before initiating aromatase inhibitor therapy. Then the side effects are osteoporosis and hot flushes, and the osteoporosis can be, and increased fracture rates will be there. So if there is, that can be counteracted by bisphosphonate. Then we have ovarian ablation, which can be done with medically, which is with the GnRH agonist, leuprolide and goserelin. Then we have ovarian radiation. Both these are used in premenopausal patients. All three are used in premenopausal patients, and oophorectomy. It decreases the estrogen effect on the breast. Decreases the amount of estrogen, suppresses estrogen, and then therefore there is suppresses estrogen. Anti-HER2 new therapy is we have trastuzumab, pertuzumab, and lapatinib, which sir has already just mentioned. Trastuzumab is a recombinant monoclonal antibody, and it can be used in neoadjuvant as well as adjuvant settings. And pertuzumab is given in conjunction with trastuzumab in neoadjuvant settings, which improves the pathological response rate, and also is used for metastatic HER2 positive disease. And we have lapatinib, which is given, it is a dual tyrosine kinase inhibitor, which inhibits HER3 as well as HER2. And trastuzumab pertuzumab can be given along with chemotherapy. Next slide. Radiotherapy. The indications for radiotherapy is tumor more than 5 centimeters, lymph nodes more than 4 are positive, grade 3 of primary tumor, and after BCS, all patients will receive radiotherapy. Methods of irradiation is whole breast radiation. Then we have chest wall radiation, regional nodal radiation, which has axillary, supraclavicular, infraclavicular, and internal mammary. It's supposed to be internal mammary regions. And accelerated partial beam irradiation, which is experimental and has to have extremely high patient selectivity, such as T1 tumors complete resection needs to be done. It has to be hormone positive tumors, and in postmenopausal women is what accelerated partial beam irradiation criteria is. Next slide. Finally, we have to go for breast reconstruction post-surgery. We have methods. We have implants, which you can use, which has water or silicone gel implants are there. Then we have autologous tissue, which has pre-flaps or pedicle flaps. Oncoplastic methods, which is done along with breast conservation surgery, and the tissue is rearranged during the surgery. It usually requires bilateral surgery in order to achieve adequate symmetry. And skin grafts. Skin grafts is only a temporary measure to bridge the time between the surgery and the radiation. The issue with breast reconstruction is that it can be done either immediately or it can be done in a delayed manner. Immediately, it is preferred to be done after radiotherapy, because radiotherapy will have an effect on the flap or the implant that is placed, which causes shrinkage of the implant. It causes malpositioning of the implant and flap necrosis and infection. And so hence, we will try to do a delayed reconstruction or a phased reconstruction. A phased reconstruction is during the initial tumor excision surgery. We will put in a implant tissue expander and then send the patient for radiotherapy, which is the tissue expander is placed beneath the pectoral muscles, so as or in order to create space. And then patient completes radiotherapy, and then following that the reconstruction is done. Next slide, please. Obesity and smoking are extremely important causes that need to be checked, which cause high flap failure rates, and hence there are relative contraindications for flap reconstruction. Now, the flaps that are commonly used is LD myocutaneous, latissimus dorsi myocutaneous flap, which use the thoracodorsal vessels is the pedicle. Then we have abdomen-based flaps, which can either be free flaps or pedicle flaps. We have the transverse rectus abdominis myocutaneous flap. We have the deep inferior epigastric perforator flap, which is the deep inferior epigastric perforators. And we also have non-abdomen based flaps, just either gluteal flaps or the gracilis flaps. And the nipple area areolar complex, it has multiple methods of reconstruction, but the best way is a local skin flap rearrangement and tattooing for color. Thank you.
Thank you, Malavika. You can, come back to your own form, stop the skin sharing option.
Yeah.
Now, the time is pressing. We are almost towards the end. So my observations are I will, I mean, you have given an overview of all the forms of treatment. Now, point number one, how will you differentiate an inflammatory carcinoma from a non-inflammatory poderonge?
Sir, a skin biopsy can be taken
Clinically?
Clinically, so there will be poderonge, there will be satellite nodules or ulcerations, lymph nodes will be positive, and the involved breast is, it is skin is.
There are certain criteria. The criteria are number one, a patient presents with rapid onset and rapid progression. Number two is you find on clinical examination presence of poderonge in more than 33% or 1/3 of the quadrants of the breast. So in a localized poderonge, there may be a small area of 1 to 2 centimeters. That does not qualify it to be inflammatory cancer. Inflammatory cancer, the poderonge has to take at least more than 1 quadrant or 1/3 of the breast. Number three, you find signs of inflammation and redness over the skin, which you normally do not find in non-inflammatory cancer. Finally, if you look and try to palpate, you rarely, if ever, will find a well-defined discrete lump. It's an ill-defined presentation, I mean, induration of the breast with overlying gross poderonge. Rightly said, you can go for a core biopsy under ultrasound guidance. Why? Because in an inflammatory cancer, the lump is you are unable to fill the lump. So you need to focus a core biopsy under ultrasound guidance. And number three, if it fails, then you have to take a full thickness dermal biopsy that demonstrates the blockade of the lymphatics. Clear? Number three, you told, I think in your presentation, inflammatory breast cancer as 3B, but what will be the TNM of inflammatory breast cancer?
T4, either T4A will have involvement of the skin, and
it becomes T4D.
I'm sorry, T4D.
Yes.
Okay, there's both involvement of both.
Okay. So this is one area which you must remember for your exam. The second area is, as you rightly said, in locally advanced breast cancer, the treatment of choice is neoadjuvant systemic therapy. No confusions about that. What is the advantage of neoadjuvant systemic therapy? Number one, there is a trial which shows that generally the survival does not improve, but the breast conservation surgery rate improves. This is the generic statement. Yes. I also believe in statement for till 2017-18. In around 2016, there was a major publication which came out in Lancet, following which it was shown that if you are dealing with a triple negative breast cancer, mark my words very carefully, if you are dealing with a triple negative breast cancer or an HER2 enriched cancer, if you are able to achieve complete pathological response by giving neoadjuvant systemic therapy, then the survival improves. Yes. Before that, it was told the survival does not improve, only improvement is breast conservation. But following the Lancet publication, it was told that in HER2 enriched cancer and triple negative breast cancer, you are going to get a survival benefit if there is a complete pathological response. So this was a landmark trial. Following that, the policy for neoadjuvant systemic therapy is for triple negative breast cancer or HER2 enriched cancer, use all possible means to achieve complete pathological response before you go plan for surgery. So in triple negative breast cancer, use 6 cycles, then surgery. But in luminal cancers, as you rightly said, the effect of chemotherapy is not so strong. So in them, there is no point in continuing chemotherapy for 6 cycles. You can operate after 3 cycles if you find that the cancer has become operable. So the policy is very clear, and the landmark trial is the Lancet trial. if it is a HER2 enriched or a triple negative, you use as much of neoadjuvant systemic therapy, whereas in case of luminal cancer, you operate once it is operable. Clear? Now, your role is to achieve complete pathological response. And before complete pathological response, many of them will have complete clinical response. That means as you palpate, you are unable to find anything. So this might happen. So you are supposed to put in a marker at the central core of the tumor, so that even if there is a complete clinical response, you know that that marker, perimarker area excision is going to be your surgical target. Clear?
Yes.
Now the question comes, how much is a clinical response equal to a pathological response? The answer to the question is not necessarily. Even if you have a good clinico-radiological response, after surgery, it is unpredictable that it is equal to pathological response. The pathological response may not be the same. So therefore, even after neoadjuvant systemic therapy, even if you find that the tumor have decreased completely clinico-radiologically, a marker-guided excision becomes mandatory. So no surgery as of now is not an option. Clear? The third question that I am going to tell is, what is the role of neoadjuvant endocrines? The role of neoadjuvant endocrine is only in ladies more than 70 years of age having ER/PR positive. So in them, instead of neoadjuvant systemic therapy, you are supposed to give endocrine therapy as neoadjuvant form. But in other groups, you want response to happen earlier, so chemotherapy is the choice. Clear? Thank you very much, sir. I think we are.
Yes, we have excellent time. So we have a nice discussion. Dr. Bosak, you want to make a last minute comment?
Very good discussion. Very good discussion, Dipten. Thank you. Very good discussion. Thank you.
Thank you. Okay. Thank you, Dr. Sarkar. You have a nice coverage of the topic.
Sir,
Thank you,
sir,
Malvika.
sir,
Yes.
Thank you.
Yes.
We must state everyone before it officially comes up, the dream SASICON that you are going to conduct. Sir, on behalf of sir, let me announce here that an historical SASICON is planned at the end of July, and it will be a wonderful combination of meeting your friends and an academics. It is a completely new form of conference that has been planned by sir. I expect all of you must be there in the conference.
Thank you. Thank you, Dr. Sarkar. Thank you.
Thank you, sir.
Thank you. Hey, class